and welcome to your Week 10 mini session on Chapter 16 for ST310 Pharmacology for the Surgical Technologists. Let's get into our learning objectives and why they're important to us. Now, keep in mind, emergency situations during surgery can involve anesthesia related issues, such as allergic reactions and respiratory emergencies. We should be familiar with the terms and abbreviations associated with these situations. Respiratory emergencies, including allergic reactions, require quick administration of medications like epinephrine or antihistamines. There are also three types of transfusion reactions that need to be identified and treated promptly just to avoid complications. Knowing how to manage these emergencies allows us to assist effectively in critical situations. As surgical technologists, it's also important to understand and address critical emergencies that may happen during surgery. Recognizing and managing bronchospasms and laryngospasms are so important for ensuring the patient's airway remains secure. Also, understanding the protocols for cardiac arrest and knowing our role during a cardiac emergency just helps us to support the surgical team effectively in life-saving interventions. Being familiar with drugs commonly used for cardiac resuscitation as well as other cardiovascular medications allows us to anticipate the needs of the surgical team and contribute to prompt, efficient patient care. These skills are so important for patient safety and successful surgical outcomes. With that, there are a lot of terms from this chapter that you really want to be familiar with and be able to compare and contrast and pick them out, okay? For example, bradycardia, slow heartbeat, less than 60 beats per minute, a potential complication during anesthesia, versus a bronchospasm, which is sudden tightening of airway muscles making breathing difficult, that is linked to anesthesia complications. Tachycardia, for example, which is a fast heartbeat, greater than 100 beats per minute, and it is an early sign of malignant hyperthermia. We're going to talk about that in this mini session. And tachypnea, right here. Rapid breathing, greater than 30 breaths per minute, another early sign of malignant hypothermia. Now keep in mind that all of these terms and conditions are so important to understand in emergencies and reactions during surgery. Okay, so let's get into it. Respiratory emergencies during anesthesia include bronchospasms, laryngospasms, and anaphylaxis. Rare but critical emergencies are cardiac arrest and malignant hyperthermia. Table 16.1 shows the generic names and purposes of drugs used for respiratory emergencies. Respiratory problems during surgery can happen for many reasons, such as blocked airways, anesthesia reactions, or other complications. Let's start with mild reactions. These include skin redness, hives, or raised patches. If early signs appear, potential triggers should be stopped immediately. Allergic reactions can develop within 2 to 20 minutes and last up to 36 hours. H1 and H2 receptor antagonists like dihydroarbutin, Benadryl basically, are used to counteract the release of histamines. If mild treatments do not work, the reaction can escalate to anaphylaxis, which is a severe, life-threatening allergic reaction with respiratory symptoms. Anaphylaxis occurs in 1 in 4,000 to 25,000 cases of anesthesia. Epinephrine is the first line treatment, and corticosteroids may also be used. If not treated quickly, anaphylactic shock can cause full cardiovascular collapse, including cardiac and respiratory arrest. We get into transfusion or hemolytic reactions. Again, rare, but an important allergic reaction that occur when incompatible blood is given during surgery. They are marked by hypertension, which is high blood pressure, hemoglobinuria, which is blood in the urine, anuria, which is lack of urine, fever, and disseminated intravascular coagulopathy, which is DIC. The first step in treatment is to stop the blood transfusion immediately. There are three types of transfusion reactions: febrile, non hemolytic, caused by antibodies attacking donor white blood cells or platelets, again, rare in surgery. We have allergic and then hemolytic. A bronchospasm is a condition where the bronchi is constricted and become inflamed, and you can kind of see in the image where there's a lot of inflammation, and that causes impaired breathing. So some of the signs would be wheezing, prolonged exhalation, decreased breath sounds, lower oxygen levels, increased airway pressure during ventilation, and hypotension. The anesthesia care provider will check for mechanical causes, but we treat with albuterol, epinephrine, which are your beta adrenergic agonists, and atropine. If bronchospasm continues, corticosteroids like hydrocortisone or others may be used, typically through IV, but sometimes we can actually have them inhale it, or will inhale it. For a laryngeal spasm, and I put a image on there where you can see normal, incomplete, or one that is completely closed. This is the involuntary tightening of the vocal cords, which can partially or completely block airway. It can happen during intubation or soon after extubation, so when we're putting the patient to sleep or when we're bringing them out. So how do we treat this? We have positive airway pressure with a mask and chin lift. We have muscle relaxants if the spasm doesn't resolve, and atropine for treating bradycardia in pediatric patients caused by low oxygen levels. Patients are most at risk when lightly anesthetized at extubation, especially children and infants. Cardiac arrest is the sudden loss of heart function, breathing, and consciousness, often called a code blue. It can happen before, during, or after anesthesia is administered. In this situation, our role will depend on the specific scenario and should include supporting the team in providing life-saving measures. In cardiac arrest situations, our role again varies, like I mentioned, depending on the position and the specific circumstances of the event. But let me break it down for you. All right, we are going to maintain, if we're scrubbed in, the sterile field while assisting the surgical team. We may help with administering medications if needed, and we make sure that the equipment is ready for emergency use. Oftentimes, there's a second assistant that assists the surgeon with procedures as needed, like holding tissue or organs during resuscitation efforts. All this does is help ensure that necessary instruments are available for the team to use quickly. A surgical first assistant works closely with the surgeon to provide more hands-on assistance. They may need to assist in advanced procedures such as chest compressions or using defibrillators. Our circulator ensures that the operating room environment is set up and ready to go for the emergency procedures, including managing medications, supplies, and communication with other medical teams. They go and grab that crash cart, which contains essential equipment such as medications and the defibrillator, and ensures it's available. But there's other people in the roles. Our anesthesia provider manages airway and ventilation. Our surgeon performs resuscitation procedures if needed and directs emergency care. Nurses and other staff assist in the resuscitation, monitoring vitals, and providing all other necessary support. All members of the surgical team must work together to stabilize the patient, and every role is important to the success of the cardiac emergency response. Keep in mind, All of us surgical techs must be certified in American Heart Association basic life support at the healthcare provider level to respond effectively in such emergencies. Now, Table 16.2 summarizes key drugs used for cardiac resuscitation. Epinephrine, often the first line treatment for cardiac arrest. We have lidocaine, given only if amiodarone is not effective. And we look at different heart functions: no heartbeat, slow heartbeat, or rapid heart rate. Okay? These drugs and terms are so important for understanding cardiac emergencies and how to treat them. We should also be familiar with the following drugs. Adrenergic agonists, stimulated. They come into our sympathetic nervous system, often used to increase heart rate and blood pressure. Adrenergic antagonists, they block the effects of adrenergic agonists, helping to lower blood pressure and heart rates. Again, like with the terms earlier, you're going to want to make sure that you understand these and are able to differentiate between the terms, okay? These are your cardiovascular drugs. Understanding these drugs are important because we may have to assist effectively during a cardiac emergency. All right, now let's go category by category. Adrenergic agonists, also called sympathomimetics, meaning they mimic, okay? They mimic the effects of the sympathetic nervous system, often increasing heart rate and blood pressure. Dopamine, norepinephrine, albuterol, these are some of the examples, okay? They block the effects of epinephrine and norepinephrine. These drugs are commonly known as beta blockers and specifically work as beta adrenergic antagonists, reducing heart rate and blood pressure. Cholinergic agonists. Now, these primarily affect the parasympathetic nervous system. They stimulate the parasympathetic system, but are not typically used for treating cardiac conditions. They block effects such as atropine sulfate, which specifically blocks the vagus nerve's influence on our sinoatrial node, the SA of the heart, increasing heart rate. Antirhythmic agents. These are used to prevent irregular heart rhythms by affecting the force of rhythm to the heart. They're classified into 4 classes. Class 1, these drugs slow the electrical impulses in the heart rate. Class 2, these drugs block the effect of adrenaline, reducing heart rate and blood pressure. Class 3, these drugs help stabilize the heart rhythm by prolonging the repolarization phase. And Class 4, these drugs relax blood vessels and reduce heart rate by blocking calcium entry into heart cells. Vasodilators, inotropes, and vasopressors. Now, dopamine and epinephrine are both classified as inotropes, which increase the strength of heart contractions, and vasopressors, which raise blood pressure by constricting blood vessels. Vasodilators are drugs that relax smooth muscle cells and blood walls, leading to widening of the blood vessels and lowering blood pressures. Inotropes and vasopressors are used to increase blood pressure by improving heart function and constricting blood vessels. All right, so that was the first part. Now we're going to get into malignant hypothermia. Malignant hypothermia, MH, is a life-threatening condition that requires surgical techs to act quickly and effectively as part of the surgical team. Recognizing clinical signs such as rapid rise in body temperature, muscle rigidity, tachycardia, and hypercapnia is critical for early intervention. Treatments involve discontinuing triggering agents, administering dantrolene, cooling the patient, monitoring vital signs closely. We play an important role by preparing and passing necessary supplies, assisting in cooling efforts, and maintaining sterile technique while ensuring the surgical environment supports efficient crisis management. These actions are crucial for improving patient outcomes in a malignant hyperthermia emergency. Now, malignant hyperthermia is rare but life-threatening reaction to certain anesthetic agents in susceptible individuals. So there's a rapid onset. Malignant hyperthermia can become fatal in as little as 15 minutes. Untreated MH has a mortality rate of 80%. Prompt diagnosis and treatment are crucial for survival. There are trigger agents for MH. Circulator is a muscle relaxant, and inhalation anesthetics except nitrous oxide. And then there's some antipsychotics. These agents can trigger MH in susceptible individuals, so it's so important to avoid them during anesthesia whenever you can. MH occurs when individuals with genetic defects, which stores and releases calcium, which is called sarcoplasmic reticulum, are exposed to certain trigger agents. Genetic inheritance is 50% of offspring inherit the defect. There's a trigger plus susceptibility. Both must be present for MH to occur. And there's, of course, a mechanism part of this as well, which is exposure to triggers causing massive release of calcium in muscle cells, leading to sustained muscle contractions, increased metabolism, the excess of heat production, oxygen depletion, and carbon dioxide buildup, resulting in acidosis. Muscle cell breakdown releases myoglobin into the bloodstream, which can clog the kidneys. Immediate treatment is crucial to prevent kidney damage and severe complications. But let's hear malignant hyperthermia, the lethal anesthesia allergy, from a doctor's point of view.
Hello from one of the most secretive and sometimes dangerous places in the world. That's right, it's the operating room, where sometimes orange-colored juice can actually be life-saving. Do you know what this orange-colored juice is? Well, it's the treatment for the lethal anesthesia killer called malignant hyperthermia. So what is malignant hyperthermia, and what do you need to know about it? Malignant hyperthermia is when your body literally consumes itself. Every little muscle in your body contracts, like makes a really strong muscle, and it makes your body temperature go up, like you're doing a massive body workout. The problem is that you're not really getting swole or getting gains from this workout. You're just increasing your risk of lethal cardiac arrhythmias, kidney failure, and in general, death, because literally every cell in your body is just contracting and releasing toxic compounds into the rest of your body. The reason why anesthesia is important to malignant hyperthermia is because anesthesia gases like sevoflurane or IV agents like succinylcholine can actually trigger malignant hyperthermia. They literally trigger your body to go into this hypercatabolic state and makes every single muscle contract and releases all those toxic compounds and can ultimately lead to death. That's why we need to give you very, very special anesthesia, which is why we need to know about it ahead of time, which is why you need to tell us if you have a first-degree relative with malignant hyperthermia because of the heritable component to malignant hyperthermia. Fortunately, malignant hyperthermia is very, very rare. It's like one in the order of 100,000 or so general anesthetics. But the mortality is real. Even in the modern 21st century, it's still in the order of 5% mortality, which is why we always need to have the orange juice immediately available anywhere anesthesia is being delivered. There's actually a very specific mixing process for mixing dantrolene, and you have to be able to do it very quickly in an emergency scenario. You have to use sterile water and mix that with the dantrolene, and it becomes this amber orange colored juice that is the only definitive treatment for malignant hyperthermia. So, the good news is that we can treat this when it's identified early, which is why you need to tell your anesthesiologist if you have a first-degree blood relative, like a brother or sister or mom or dad, who has malignant hyperthermia, because the gene mutation is actually heritable, and you're at increased risk if you have a first-degree blood relative with malignant hyperthermia. There's also a whole bunch of other things we do to support your body while you're still asleep if you're suffering from malignant hyperthermia. It's actually not just dantrolene, which is the treatment, it's also managing the ventilator and giving other medications like epinephrine to help prevent cardiac arrest from ultimately causing a heart attack or stroke. So today, I ran a drill with my team here to make sure that we all know what to do should malignant hyperthermia happen. It's kind of like flying an airplane where most times everything is just fine because you've prepared adequately. But sometimes unexpected things happen, like an engine failure or, I don't know, a bird goes into your windshield or something, and you need to be prepared with your team on how to address those catastrophic scenarios. That's what we did today. So we actually used a bunch of expired medications so we don't waste this stuff because, yeah, it's really expensive. And we were able to demonstrate a mock scenario with the mannequin, with the CPR and everything, ultimately saving the mannequin's life. But I just want you guys to know that if you're ever coming into the operating room, even though there are dangers, be confident that your team knows what they're doing and your doctors have been training for years and years and years to help lead the team when these catastrophic scenarios happen. Because we can't always predict them. If we knew everyone who had malignant hyperthermia, this wouldn't be that big of an issue. But nearly all cases are in.
What he was about to say is nearly all cases we find out, unfortunately, in the operating room. Now, the earliest signs of malignant hyperthermia are subtle, but it's so important to recognize. Increase in end-tidal CO2. This is the very first and most reliable sign. It indicates excessive CO2 buildup due to that hypermetabolic muscle activity. It can be caused by other factors, so it must be assessed along with others. There is tachycardia, which is rapid heart rate, tachypnea. Some of these sound familiar, right? From our terms, rapid breathing as the body tries to eliminate excess CO2. The Macessor muscle rigidity, or MMR, which may occur during intubation. While this can be normal, it is a classic MH sign. Unstable blood pressure and arrhythmias, which can also have other causes, but again are red flags in the context of other MH signs. There's cyanosis, which is blue skin, and diaphoresis, which is profuse sweating, which results in that heat buildup. There is pyrexia, which is high fever, which is a late sign but can rise up to 109 degrees Fahrenheit and lead to death in as little as 15 minutes. So you have immediate recognition and response. If MH is suspected, the anesthesia provider will immediately stop the trigger agents, succinylcholine and inhalation anesthetics. Then they administer that dantrolene. This is the primary treatment to reserve the effects of MH by inhibiting calcium release in muscle cells. Dantrolene should be administered as soon as possible. Then you begin cooling the patient aggressively to manage the high body temperature using ice packs and cooling blankets. Administer oxygen to correct the acidosis, and then you treat any arrhythmias or unstable blood pressure with appropriate medications. And then you monitor and assess. You continuously monitor of end-tidal CO2, the heart rate, blood pressure, and temperature is important. Why? Because MH can lead to death in 15 minutes if untreated. So we get into the protocols. Again, this is rare, but a serious reaction triggered by certain anesthesia drugs. It can be fatal if not treated quickly. Symptoms include rapid heart rate, breathing difficulties, muscle rigidity, high fever, and unstable blood pressure. And I know we keep saying it, but it's important to kind of get these so that you can notice, hey, something's not right. Hyperventilation with 100% oxygen helps eliminate that CO2 from the body, which builds up during MH. Again, dantrolene, a muscle relaxant that stops the abnormal muscle contractions caused by MH. Sodium bicarbonate, used to treat acidosis, which is that excess acid that's happening during MH. Again, we're cooling the patient. Ice packs is crucial to prevent brain damage. Sometimes we use diuretics like mannitol, prevents kidney damage by helping to flush out harmful substances like myoglobin that is released from muscles. And then there's insulin to treat high potassium levels caused by muscle breakdown during MH. We need to know our roles. Be familiar with the drugs and equipment used in MH treatment. Assist quickly, help with oxygen administration, cooling, preparation of medication. Support the anesthesia team and make sure everything is ready for treatment without delay. We have to act fast and stay calm to help manage this life-threatening emergency effectively. First and foremost, stay alert, focused on the patient and the environment. If you're not paying attention, you can't help identify or respond to a crisis early on. Awareness is key to providing effective assistance when needed. Again, be aware of the clinical signs of crisis and be prepared to act quickly. Focus on the patient and assist the anesthesia provider as needed. If MH is suspected, the anesthesia and surgery stop immediately. If the procedure continues and you're in the first scrub role, stay sterile, monitor the surgical site, and assist as needed. You may also help by handing over iced saline irrigation. In the second role, if necessary, you may break scrub to assist in getting ice, bringing in more help, or reconstituting dantrolene if no one else is available, such as during on-call situations. In the circulator role, we are tasked with setting up ice bag lavages for areas like the bladder, the rectum, abdomen, and again, reconstituting dantrolene for administration. In an MH emergency, tasks happen so quickly in parallel. Knowing the procedure and being prepared to act helps the team respond effectively. Stay calm and focused. Patients at risk of MH will not be given triggering agents to prevent a crisis. MH is one of the many emergencies that occur in surgery, and each requires quick thinking and support from the surgical tech. The more knowledge you have, the better you'll be able to assist the anesthesia provider and respond effectively in any emergency situation. So what did we cover? This chapter covered the critical role of what we do in emergency situations like MH, which is a rare but life-threatening condition triggered by certain anesthetics. The key to responding to MH is recognizing early signs such as increased CO2, tachycardia, muscle rigidity, and fever. Early action is important, including hyperventilating with oxygen, administering that drug, dantrolene, and using ice packs for temperature control. We play important roles in these emergencies, whether as a scrub, second assistant, or a circulator. Being prepared, staying calm, and knowing what steps to take can make a significant difference in saving lives. And this is, again, Chapter 16, Emergency Situations. Looking forward to everyone who can attend the live session. Also, if you have any questions, please do not hesitate to reach out.